Now I have Dr. Benadir on multiple MP ultrasound and contrast enhanced ultrasound for real-time determination of ablation marks.
Hello, everybody. So I just want to preface with, when I was given this topic, I hadn't personally utilized contrast-enhanced ultrasound, and you know, speaking to a lot of my colleagues, some of them have tried it a handful of times, but I don't know anyone who consistently uses this, but I find it very interesting. And so if anyone has consistent experience and wants to step up to the mic after this talk, just to shed some insight, that would be really great. But I just want to start with this quote as well, because it really spoke to me. You know, nothing spoils good results as much as follow-up. And, you know, some of us just came back from Korea. We know the sharpshooter here. Sometimes as focal therapists, we feel this way. We feel like we follow the Falcon and the Delphi consensus. We've picked a great patient for focal therapy. The imaging looks phenomenal. We're treating the patient, we see cavitation, we see hydrolysis, we're high-fiving our residents, we leave and there's a recurrence. And so, because we're urologists, you know, who can we blame? And so is it the patient's fault? Is it imaging limitations, or is this treatment failure? And just speaking a little bit about multiparametric MRI limitations, we got to think about this in terms of diagnostic therapeutic, but also pragmatic. And so, in comparison to grayscale ultrasound, we know this is vastly better in terms of we have a standardized PIRAD score, and as we move up in the PIRAD score, there's evidence of higher rates of clinically significant prostate cancer. But MRI visible limitations and MRI invisible limitations exist. The slide at the bottom left, the image, we actually showed this yesterday. MRIs underestimate true lesion size by about 8 millimeters, and that size gets bigger as the PIRAD score gets lower or as the lesion gets lower. But also, this was a really nice study. I think I was a fifth-year resident when this came out of UCLA, and you know, this study really spoke to me is that if you look at the graph, the upward is detected and the bottom is missed. And you can see that a majority of missed things are non-index lesions and largely indolent lesions, but there's still some clinically significant prostate cancer that's missed. And you know, I would argue that missing a 4+4 or a 4+5 you know, is quite significant. And so we do have limitations in terms of MRI invisible lesions. And when we think about pragmatic limitations, there's availability, there's cost, there's low inter-reader agreement. I think Dr. Abreu showed a slide on Friday that even among experts, there's 50% agreement. And then there's the problem of patient and prostate movement. And you can imagine if you have a community radiologist who has difficulty reading the PIRAD score, how are they going to do it when you've treated as well? And so when you've had prostate deformation from treatment, co-registration errors, and unless you're you know, best friends with the Department of Radiology, starting a program in Tulsa or trying to get some MR-guided focused ultrasound is a huge challenge. And so there are some pragmatic limitations. But if we compare this to the grayscale ultrasound, this is available, it's familiar, it's low cost. Problem is we can't reliably detect prostate cancer with it. We can't reliably use this as a marker of treatment success. I think we've come a long way in terms of the evolution of ultrasound. You can see here we have Doppler. In the middle, we have contrast-enhanced ultrasound, histoscanning on the far right. Elastography is the cool one that has different shades of blue and green, and that looks at mechanical and shear stress to the prostate. And then we just presented a micro-ultrasound. Now, what is multiparametric ultrasound? Well, it's a dealer's choice of 3 of these modalities. And so you pick the 3 and you come up with your clinical endpoint. But for the purpose of this talk, I'd like to focus on contrast-enhanced ultrasound. Now, contrast-enhanced ultrasound, I took this picture of a tree because it's going from larger branches to the smaller ones. And it's from a macro to micro phenomenon. So Doppler ultrasound can detect macrovasculature up to about 200 micrometers, whereas contrast-enhanced ultrasound looks at perfusion as low as 40 micrometers. Now, why does this matter? Well, it takes advantage of one of the hallmarks of prostate cancer, which is angiogenesis. And with angiogenesis, as you guys know, there's smaller blood vessels, and so there's a higher surface area in prostate tumor foci. And if there's a higher surface area, there's less resistance. So therefore, there's faster flow. And so you're going to see early enhancement. But you also have to have microspheres that enhance. And so this is the principle of contrast-enhanced ultrasound. Now, how can we utilize this in focal therapy? Well, in 2011, Revere had a study. He had 8 patients that had undergone contrast-enhanced ultrasound before HIFU and then after HIFU, and then he did a biopsy at 30 to 45 days. And he created a score. It's a simple score. 0 is no enhancement, 1 is mild and patchy, and then 2 is marked enhancement. And this is a very small study, but what you can see is that even in S0, there was still some viable tissue in 6.2%. But when you compare that to S1 and S2, it's vastly different. Now, the limitation of this study is viable tissue benign or malignant? We don't know from this study. But what you can potentially conclude from this is that a score based on contrast-enhanced ultrasound can be associated potentially with viable tissue. Well, what about with IRE? Well, Neeson in 2015, they looked at 13 patients undergoing IRE, and what they did is they used contrast-enhanced ultrasound before, during, after, and 24 hours after IRE, and they had this 5-point microvascular scale that's depicted here. And what they saw was that immediately after you do IRE, there's this clear demarcation of the treatment zone, and you can see that in the image at the top left followed by top right. And when they looked at the microvascular scale, immediately after the scale drops from about 2.2, 2.3 down to less than 1, and then 24 hours later as well, it continues to decline. And so you can conclude from this that in real time, you can see clear demarcation, at least with IRE. Now, does that last? Well, this is a really cool study where Vanden Bosch, it was a prospective phase 1 and 2 trial where these men were destined for radical prostatectomy. But what they decided to do is make their lives a bit harder, is that before they did radical prostatectomy, they did IRE. And so they performed a contrast-enhanced ultrasound, IRE, and then 4 weeks later, they did another contrast-enhanced ultrasound. They also added MRI and grayscale. And what you can see here is that the 4-week post-IRE, so right before the radical prostatectomy, there's still this clear demarcation of the treatment zone in the middle row here. And you can also see on dynamic contrast enhancement, it's quite clear, but just proof that you can't really use an ultrasound to help you out is that you can't really see treatment effect on the grayscale. And the nice thing is that this also correlated with necrosis borders on whole mount pathology, so really neat study. But we got to go more long-term than that. So if you look at 6 months and 12 months, and these are 2 separate studies, the actual ablation zone shrinks. And this coincides as well with shrinking of the prostate size. And so the study from the top showed that the ablation zone can decline at about 6 weeks, and then by 6 months, it's declined by about 40 to 42%. The question I have is, well, does that coincide with treatment failure? We don't know the answer to that. But this is an interesting finding to show you that demarcation doesn't last forever. Now, there was a study from USC, and I really commend them on this aspect of the study, where they utilized the time intensity curves. And I had never heard of this until I read their paper. And what it is that with contrast enhanced ultrasound, there's a proprietary software that can measure these intensity curves. And if I can draw your attention to the third picture, where there's a yellow circle around where the prostate foci is, and then a green circle where there's no cancer, and then draw your attention to the fourth image that are curves. What you can see is where the cancer is, so the yellow line, it has a steeper curve. It's earlier in its incline, and it washes out quicker. And so it has a higher peak, steeper, and it's earlier. And so what's, you could probably draw from this is you can slide these curves and maybe identify a margin. And, we've been talking about, recurrences happening at margins, whether that's significant or not. Well, this is real-time assessment of where your margin starts and stops. But you can take this one step further, and once you've treated, you're still in the OR. We're not talking about 3 months later, 6 months later. You can then slide your curves to margins and look, well, do I now have a flat curve? Do I have minimal slope? Or is it still rising? And so, I don't know if people have done this study looking at margins yet, but this is how I would utilize it. Now, in terms of whether or not this changes management, Bacchetta in 2020 did a study where they performed HIFU and then they did a contrast-enhanced ultrasound. If the surgeon was concerned for whatever reason, he did HIFU again. Now, the outcome was clinically significant prostate cancer at controlled biopsy, and I'll explain what controlled biopsy means in a second. They also looked at concordance of contrast-enhanced ultrasound with an early multiparametric MRI at 5 to 10 days, and then saw, well, does it add values to any areas under the curve with other predictors of clinically significant prostate cancer in this patient population, which would be a concerning late multiparametric MRI, a concerning PSA density, and a PSA you're not happy with at 6 months. And so In terms of results, they had 32 lesions. They saw that S0, so if you can recall from Rouvier's study, S0 is no enhancement. It was in 64% of patients. And so there were still 36% of patients that had some enhancement immediately after HIFU. And what's interesting is that based on this, the surgeons performed repeat HIFU or the double pass or whatever you want to call it, dose escalation in 39% of patients. So at least in this study, it changed management. If you draw your attention to the image, you can see there's a contrast-enhanced ultrasound with some enhancement on the bottom left, and that coincided with the early multiparametric MRI. They concluded that the concordance with this was 73%. Now, the results, a little concerning. The clinically significant prostate cancer was 30% in the treated area and 20% indolent disease in the treated area, and that's quite high. But you have to remember that this was biopsy for cause. This wasn't biopsy for contrast-enhanced ultrasound. They did it for patients who had a concerning PSA density, multiparametric MRI that was late that was concerning, or a 6 months PSA that was concerning. So had they utilized contrast-enhanced ultrasound or performed biopsies and all, this number would probably be smaller. And when you add contrast-enhanced ultrasound to the areas under the curve, it rose it to 0.881. Now, in summary, we can say that post-focal therapy S-scores, they're potentially associated with viable tissue. It clearly delineates ablation zones immediately to about 4 to 6 weeks. These defects, they do involute over time, but who knows if that's associated with recurrence or not. There's these time intensity curves that are, in my opinion, underutilized that could be quite helpful in real time, where you can readjust whether or not you want to treat wider. And then in some cases, it does change management, but if you're someone who does double pass, does it really change management in your situation? And it'd be interesting to know if it changes outcomes. Thank you.
Thank you. So those were really fantastic series of talks, and I had very difficult questions for all of you, but unfortunately we're quite over time, so I think we probably forego the QA.